Okay, if I don't finish with mood disorders in this section, I am hoping that it's just a sliver left for Friday. But we're going to do mood disorders part 3 now. So in the very last slide of the last PowerPoint, I mentioned treatment-resistant depression. So people who are really not responding well to either therapy or medication. This really is about a third, maybe the estimate is maybe as many as half, but probably more closer to 1/3 of the people are not responding well to either therapy or medication. And the one thing they have tried is electroconvulsive therapy, or ECT, sometimes called electroshock therapy. This has changed over the years, and my feeling towards it is not super positive, but I think it's because because it is scary, and because it has had kind of a bad rap, because ECT used to be used. It was first used for schizophrenia and people who were kind of not easy to control. And it really didn't work for those people. And what they decided was that it was helping more. It could help people with depression. And even the way we use it has changed a great deal, where they used to sometimes in institutions use it again for people they couldn't control and they just used it. But now we make sure that we get informed consent. So the person is saying, I have a severe enough depressive disorder. It is causing me enough distress that I consent to having ECT. It usually happens about 3 times a week until maximum improvement. There's usually about 6 to 12 treatments. Sometimes people do relapse and have to go back for additional ECT after a while, or supplement with drugs or therapy or something else after getting that original ECT. Now they use muscle relaxants or anesthetics, so that it's not this. It was not just scary, but actually painful and horrible experience before. The most common side effect was memory loss, which lasts at most a few months, but it used to look to me like, and again, I have a little bit of a negative feeling towards ECT, but I think it's mostly because I haven't seen how much it can help people. But if you're having memory loss, which lasts about a few months, and then you might relapse within a few months or a little bit after that, then what's really the help? But that's not really the way it works anymore. They are now limiting the ECT to the right hemisphere. And if you notice that it's the left area being more active that is helpful, and that language and all of that is in the left hemisphere typically. And so this limiting that electroshock to the right hemisphere, they're basically causing a seizure, but doing that just in the right hemisphere lessens the memory loss. And they do have a high relapse rate, where usually they supplement with drugs, therapy, or additional ECT soon after. My mom swears by ECT, that she has seen people get a lot better, and she's actually been out there in the field working with people who are dealing with treatment-resistant major depressive disorder. I have also seen one, I think it was something on YouTube. I can't remember if it was a TED Talk or what it was, but it was a doctor, not a neurosurgeon, but like a doctor, and he was talking about how his depression was causing it so he could not do anything anymore, and he ended up giving the informed consent for ECT, and it changed his life. And he did start then supplementing with drugs and therapy, and that just turned things around for him. So I think for people who have treatment-resistant depression and are at a point where it's kind of this psychotic depression, ECT can be very helpful. What's happening with ECT other than a seizure in the brain and having some memory loss that might help us not remember how miserable we were? That's not all that's happening. ECT also increases the proliferation of new neurons in the hippocampus. So we see that same neurogenesis that we saw with antidepressants, but now there is this kind of a bit of not remembering everything that was terrible, and allowing ourselves to create new connections, as we talked about, neurons that fire together, wire together. ECT also alters the expression of at least 120 genes in the hippocampus and frontal cortex alone. So if we look at the epigenetic effects, it looks like ECT is having a powerful influence on people. Other therapies, one is they've tried deep brain stimulation, and what they've gone in and stimulated is the white matter of the cingulate cortex in both hemispheres. So that area where I've mentioned that area being really active in people who are, well, we've talked about it as social pain, and when we're in physical pain, when we're really miserable, here's our cingulate cortex reminding us that we're miserable. People with obsessive compulsive disorder, it's really active, and people with depression, they're ruminating. They're thinking about the things they feel guilty about and the things they feel bad about. And so if we stimulate that region, that appears to help. Regular, non-strenuous exercise daily seems to help. I'm going to get back to our exercise. And for seasonal affective disorder, bright light therapy appears to help. So people sitting under a particular kind of lamp that has at least 2,500 lux for more than an hour each day. You can buy these lamps, and they can help you through those times when you aren't getting out in the sunlight quite enough. This is really more helpful, so that major depressive disorder, or that is happening seasonally, or what we call seasonal affective disorder, it tends to occur much more as we get into areas where it's very cold and there is not a lot of light during the day, and especially those areas that have maybe 4 or 5 hours of sunlight a day in the depths of winter. But I honestly feel like I have some seasonal affective disorder. It was terrible when I lived up in Illinois. It's not as bad in South Carolina, but I do a lot worse in January, February, and March at the end of that winter season than I do at any other time of the year. And my mom did get me a bright light lamp that I use, but not as much as I should. And I can't strongly enough talk about the importance of exercise and its role in neurogenesis. So what this picture is showing in A are these various areas of either the hippocampus itself, so the dentate gyrus and CA1, or areas that are communicating to the hippocampus, like the entorhinal cortex. And then in B, it's showing where there is more blood flow in the people who were put on this program of aerobic exercise. And as we're getting more blood flow to those areas, we can get more neurogenesis, or more of those neurons staying alive after they are created. And aerobic exercise appears to help this about the same percentage of people as antidepressant drugs. I'm going to walk through some of these altered sleep patterns, although we've talked about this now in wake sleep cycles and earlier in major depressive disorders, so I'm going to do it quickly. Teenagers who reported daily problems falling asleep, within 6 to 7 years, more than half developed depression. Altered sleep patterns do often precede depression, and they precede depression in time, but as I said, it's not that I have a sleep problem and so I'm likely to become depressed, so much as if I'm depressed, I have sleep problems. One of a pretty common type of problem is that they are, for people who have major depressive disorder, is that they are falling asleep quickly. They enter REM sleep very quickly within 45 minutes. They have increased eye movement during REM sleep. And then they also awaken early. So when I'm saying early, I mean 3, 4, 5 in the morning, and then they cannot get back to sleep. Altered sleep is a lifelong trait in people who are predisposed to depression. And we've talked about the Aurora gene as well, and not being able to get to sleep, but sleep problems are usually part of depression. Okay, and I am going to start talking about bipolar disorder today. So when we look at the unipolar disorder or the major depressive disorder, this is characterized by alternating states of normality, of feeling a sense of homeostasis and yes, okay, some kind of maybe equanimity, and depression, those episodes of depression. Whereas bipolar disorder, what used to be called manic depressive disorder, is characterized by alternating states of depression and mania. And as I said before, there's a bipolar 1 and a bipolar 2. And I'm going to distinguish those again briefly because we've already done that. And each of these, we see approximately 1% of the people have bipolar 1 or bipolar 2. One thing I like to show, I don't think this is from your book, but I like this figure a lot, as a picture is worth 1,000 words, as the brain's use of glucose increases during periods of mania and decreases during periods of depression. So normally what we see, if you remember what we've seen so far in our brains, when we've looked at brain activity, there's been a lot of green. There's been a lot of green and yellow, and when something's really happening somewhere, we might see some yellow and red, and when we see something really not happening somewhere, we see blue. And this is a bipolar. These are PET scans of a person with bipolar disorder. May 17th, 83, they have depression. May 27th, 83, they have depression. May 18th of 1983, they have the mania part of that. And you can see a lot of blue in the states of depression, that there's just there's less brain activity overall in comparison to the quote normal brain. But when we look at what's happening with people who are in their manic stage, I sometimes refer to this as brain on fire. There are areas that are red. There are areas that are yellow and red, showing a lot of activity. And that frontal area, I'm assuming, is at least including the anterior cingulate cortex. If we look at the genetics for bipolar disorder, there is a genetic predisposition. This is supported by twin studies and adoption studies. If we look at just the concordance rates among identical twins, that has been estimated, depending on the study, to be as high as 40% to 70%. There is a significant overlap in the susceptibility genes for bipolar disorder and schizophrenia. And I have already said once, and I don't know how often it's in these slides or how often I'll say it, but bipolar disorder is one of the most likely disorders to be misdiagnosed. So they can be misdiagnosed as schizophrenic during their manic phases, as they tend to be delusional. They can be misdiagnosed as depressed if they're having those depressive episodes. They can be misdiagnosed as borderline personality disorder because of some of the overlap of what's going on with the behavior. But there's a significant overlap with those genes between bipolar and schizophrenia. However, there do not appear to be any genes that have any specific gene that we can point to that has a strong relationship with bipolar disorder. So the first treatment I'm going to talk about is lithium, and I'm going to give the history because it's fascinating to me, and it's just a fascinating thing. So John Cade was a chemist, and back in the late 1940s, he was doing research with guinea pigs, and he gave the guinea pigs urine of people with bipolar disorder, so people who they called manic depressives. And those guinea pigs died. That urine had a toxic effect on them, and it appeared to be the uric acid. But uric acid did not dissolve well in water, so he added lithium to help the uric acid dissolve, because that appeared to be what was causing the death. When he gave this lithium urate now to the guinea pigs, it not only calmed them down a great deal, but then he gave the urine of the people with bipolar disorder to those guinea pigs, and that lithium urate had a protective effect on the guinea pigs. Okay, so he had done the animal studies, and he couldn't just try this on people because we just don't move to human studies that quickly, and so he he tried this on himself. He took the lithium urate himself, and he was fine. And so then he tried it on, I think it was 14 patients, and they all got a lot more calmer. And then we did not see quite the manic depressive episodes that we saw. If we go back to what I was saying in the very first kind of the first lecture of, if we're at a place of homeostasis, and if I draw a figure where there's a line that's showing mood on the y-axis and just time on the x-axis, and we're looking at homeostasis, what most of us do is we have some highs and some lows that are kind of close to that line. What people with major depressive disorder tend to do is they tend to stay a little bit below the line, maybe at the line. They're not getting above the line, and they're having these episodes of going down into these depressions. And as I mentioned with bipolar disorder, what we see is they're going up into these manic stages, whether that manic stage is with the self-confidence and the fun and the bipolar 1, and I get the impulsive reactions and some of the positive aspects, or whether that is bipolar 2 and I'm just having a lot of energy, but tinged with maybe irritability and anger. But I'm going up and I'm going down. And you might think of this as the behavioral activation versus behavioral inhibition, maybe system, but not completely. But as we go, how down I go below that is dependent on whether or not I have depressive episodes. But what lithium does is it really keeps people at that homeostasis, right along that line. And that, for most people, feels like most people aren't there, right? We're kind of going above and below a little bit. You know, we have pleasure, we have bad times. That's kind of all normal. But they're really feeling this kind of where there's not a lot of variability. And so a lot of people who are taking lithium don't like it. And I'm going to go ahead and jump to the cognitive behavioral therapy can really help, as the therapist can remind the person of some of the problems they were getting into because of not being on medication. Even if they like the highs, you know, some of it was not helpful, and then they also had some lows. And so cognitive behavioral therapy and psychotherapy usually leads to better outcomes than just putting someone on medication. But lithium is something that works, but it really keeps them at a level of and a lot of people don't like it. So other things they've tried are anticonvulsants, so valproate, Depakote or Depakine, carbamazepine. I don't really know that one as well, but those other ones I know are anticonvulsants that we can see people use if they don't quite have, even if they have epilepsy, but especially if they have some aspects of epilepsy, so it's keeping them from those seizures. That helps. People have tried antidepressants. It's kind of risky because typically this leads them to, this gets them out of the depression, which might lead them into a manic stage. People have tried antipsychotics, which have the same side effects for anybody who is schizophrenic, and yet they also are not dealing with the depression. And as I said, bipolar, I hope I said now because I had to start this slide a couple times, but I hope I said bipolar disorder is really misdiagnosed very often. And so it's not, once we know somebody has bipolar disorder, the best thing to do for them is to get them on lithium, but they really might hate it and not be willing. And then most likely we should try anticonvulsants. And again, therapy helps provide better outcomes, just mostly because, well, partly because we can help them deal with their interpersonal relations, but also just to convince them that they have better interpersonal relationships when they are on these drugs and they need to stay on their medication, but also to talk to a therapist. For the treatments for bipolar disorder, I'm going to start again by saying that cognitive behavioral therapy, in addition to the medication, is very helpful. But what's happening with the medication, if we look at lithium and anticonvulsants, really the medications that help people with bipolar disorder, some of the mechanisms behind those. One is they decrease glutamate activity, and specifically they are decreasing the number of AMPA receptors, those particular glutamate receptors, in the hippocampus. We've talked about the importance of this for learning, but having too much glutamate is a bad thing, okay? And then they also block the synthesis of the brain chemical arachidonic acid, which is produced during brain inflammation. Another thing that helps is omega-3 fatty acids. So if I have not talked about these enough, then I apologize. I hope I talked about them. One, when we talked about just neurons versus glia, and that those glial cells, all of the glial cells, but we're going to talk about oligodendrocytes that make up the myelin sheath so that we can communicate more effectively, more efficiently. That those are made up of fats, and we need a certain balance of the omega-3 fatty acids to the omega-6s and omega-9s. And in our society, we particularly tend to get too many of the omega-6s and omega-9s, but it really appears to help to have a lot of the omega-3s. And so whether or not it's helpful, I'm still doing research on that. Some people suggest that maybe the omega-3s that I'm taking by pill are not crossing the blood-brain barrier, but I have not seen that very often, but one research study does show that. I also eat a lot of fish, and especially the mackerel. I eat salmon that has a lot of fatty acids. I eat mackerel because they're the small fish. There are a lot of small fish that are really good with this, and a lot of them I don't like anchovies and sardines, but I try to eat fish and not eat those saturated fats, because it's really getting enough omega-3s and keeping that ratio balanced that's going to help the brain a great deal. And I'm going to show that in the next slide for bipolar disorder. But I've read one person who, so Dr. Daniel Amen, I don't agree with everything he says and everything he does, but his first line of defense, whether you have depression, bipolar disorder, ADHD, regardless kind of your problem, he suggests start out, before you go take a prescription drug or do anything, start on your omega-3 and start with your aerobic exercise and see how you feel, and then we'll see where to go. So I take a lot of stock in the getting enough omega-3s. Another important thing is for people with bipolar disorder is a consistent sleep schedule. And that can be difficult when they are on those really high swings of energy, but they can force themselves to sleep. Okay, what they usually do is they have this energy and they get really excited and manic and they don't sleep, but it's not that they, and there is a part of this where it's hard for them to sleep, but the better their sleep schedule and the more consistent their sleep schedule, the less they have those kind of really intense mood swings. And so that's another place where really therapy and talking to someone about the importance of that can help. My final piece of talking about bipolar disorder is just to come back to this idea of the importance of omega-3s and the possible effect of diet, which diet in general is something to keep in mind, of keeping a healthy diet. And some of those sugars and unhealthy fats are really bad for the brain in many ways. But this is a figure that is showing across different countries and cultures, which there are lots of compounds, but I'm going to show it anyway. These places like Korea and Iceland, where they eat a great deal of seafood. So if we're looking on the x-axis, this is how much seafood they're eating. And then on the y-axis, it's the likelihood of having a bipolar, having bipolar disorder or having a manic stage. We get less and less bipolar disorder the more seafood we're eating across countries. Again, very confounded. A lot goes into those kind of what's happening in a particular country. But if we're looking across a lot of countries there, and the more seafood we're eating, the less bipolar disorder we're seeing. Okay, that's my ending here, and we will talk about schizophrenia on Friday.